Welcome to the Hospital Medicine Unplugged podcast. Today, we're doing a deep dive into managing pleural effusions based on the evidence. It's a really common issue for hospitalized patients, and honestly, it takes up a lot of resources, doesn't it?
Oh, absolutely. It's a huge part of our daily workflow on the medical floors. You're looking at what, over 1.5 million cases a year just in the US? And if we don't have a sharp evidence-based approach, well, you risk spinning your wheels with investigations, or worse, delaying the right care.
Yeah, and I think something that often gets maybe downplayed is the burden of the non-malignant effusions. We hear a lot about malignant ones, but the so-called benign effusions, they're actually about 3 times more common.
Exactly. And calling them benign is, frankly, misleading. The data is pretty clear. The morbidity, the mortality associated with these non-malignant effusions, especially the ones linked to heart failure, cirrhosis, renal failure, it often matches or sometimes even exceeds the outcomes we see with malignant effusion.
That's a critical point.
And think about where the resources go. Most of the time, it's managing those underlying systemic problems, the heart failure, the liver disease. So getting that pathway right is, well, it's essential both clinically and financially.
Okay, so that sets our mission for today, to really create a clear, systematic roadmap based on the evidence. We'll walk through the initial diagnosis, how to interpret that crucial fluid analysis, and then look at tailored management, from the simple transudates through complicated exudates, right up to malignant effusions, pulling in the latest guidelines that affect how we practice.
Right. Let's start at the beginning, the initial evaluation at the bedside. I mean, the foundation is still a good history and physical exam, no doubt. But for us, as hospitalists, it needs to be really targeted. Are they overloaded? Is there an infection brewing, maybe a pneumonia? Do they have a known cancer history that just flags it for an immediate workup?
And then imaging, the old standard. Starting with the chest x-ray, well, it's kind of been overtaken, hasn't it? CXR still has a role, sure, for seeing moderate or large effusions, figuring out if it's one side or both.
But it's often not enough for quick decisions.
Right.
The real game changer, and where practice has shifted, is POCUS point-of-care ultrasound. It's really become the preferred first step now. Its sensitivity is just far superior. You can pick up tiny effusions, maybe just 20 ml, that a plain film would totally miss. And maybe more importantly, it tells you critical stuff before you even think about putting a needle in.
I think a lot of us are still getting fully comfortable integrating POCUS, especially for procedural safety. Can you expand on what POCUS findings really drive the next steps?
Sure. So POCUS does a couple of key things. CXR just can't. First, it characterizes the fluid right away. Is it simple, anechoic, or is it complex? Can you see septations, fibrin strands, loculations? If you see loculations, right, then you know a standard drain might not cut it. You're already thinking about needing something extra, like fibrinolytics, maybe multiple drains. Right. And second, using it for guiding the procedure itself. The evidence is solid here. It demonstrably cuts down major complications. We're talking pneumothorax, hitting the liver or spleen. That real-time visual check. It's just crucial for safety.
Yeah, that real-time safety aspect is huge. So CT scans then, where do they fit in? We're reserving those more, right?
Pretty much. CT is mostly for complex situations. Maybe you suspect something else is going on beyond the pleura, like a PE, or you need to get a really good look at a specific mass. Or it's used when you're planning for a bigger intervention, like VATS surgery, where the surgeon needs that detailed anatomical map.
Okay, that makes sense. So that leads us to the big decision point on the floor. When do you actually do the diagnostic thoracentesis?
Right. The basic rule holds. Any new effusion that you can't explain, or one that's only on one side, you really have to tap it. And if you're even slightly suspicious of infection or malignancy, well, you can't diagnose it without getting a sample of that fluid.
But there's that important exception that saves us a lot of unnecessary procedures, particularly with heart failure patients.
Exactly. If you have small bilateral effusions and the clinical picture screams known, stable heart failure or maybe cirrhosis or nephrotic syndrome in that clear context, you generally hold off on the tap initially. The first step is to treat the underlying systemic issue, usually with diuresis.
But you have to be careful not to miss atypical features, right? Things that would make you tap anyway.
Absolutely vigilant. If the patient has really bad pleuritic chest pain or a fever, or if one side is way bigger than the other, 500 millimolar on the right, maybe just a tiny bit on the left that asymmetry screams local problem, probably exudative, and you tap it, or if it just doesn't get better despite good diuresis.
Okay, so let's say we decide to tap, we get the fluid. What's the absolute essential lab order set?
The core panel is non-negotiable. You need the components for Light's criteria, so fluid and serum protein and LDH. You need a cell count with differential, total protein, LDH, definitely pH, cytology, and of course culture and gram stain. That initial set of tests really dictates where you go next.
And step one is usually applying Light's criteria to figure out transudate or exudate.
Correct. That's our primary tool. Just to recap, it's an exudate if it meets any of these three. Pleural fluid protein to serum protein ratio over 0.5, or pleural fluid LDH to serum LDH ratio over 0.6, or if the pleural fluid LDH is more than 2/3 the upper limit of normal for serum LDH.
We all have those criteria memorized, but clinically it gets messy sometimes. Let's talk about that big pitfall misclassification. We see it all the time.
It's the classic trap, isn't it? Especially with diuretics. Aggressive diuresis, which is standard for heart failure and often used in cirrhosis, concentrates everything in that pleural space of protein, the LDH.
Yep.
So studies show maybe up to a quarter, 25% of true transudates can get mislabeled as exudates just because of the diuresis effect.
And that leads down the wrong path.
Totally. You end up doing costly, often invasive workups looking for TB or cancer or some rare autoimmune thing when it was really just the heart failure all along.
So, okay, picture this. Clear-cut heart failure patient. You diurese them, you tap the fluid, and boom, Light's criteria say exudate. What else can we use to clarify the picture? What do the guidelines suggest?
This is where clinical judgment meets the labs. The trick is to look at markers that aren't so affected by just shifting water volume around. The serum to pleural fluid albumin gradient is really helpful here. If that gradient serum albumin minus pleural fluid albumin is greater than 1.2 grams per deciliter, it strongly points back towards a transudate.
Why albumin specifically?
Because albumin levels reflect the underlying systemic hydrostatic and oncotic pressures more directly, rather than just the local concentration effects you see with protein and LDH after diuresis. You're looking at the driving forces, essentially.
That's a great point, comparing the driving forces, not just the concentration.
Exactly. And another useful test, specifically in that heart failure patient, is the pleural fluid NT-proBNP level. If it's really high, different cutoffs are used, but often something like 1,500 picograms per milliliter or more, that's highly suggestive of a cardiac origin. It helps steer you back to diagnosing a transudate, even if Light's criteria are misleading you.
So the take-home is, don't chase that false exudate down a rabbit hole of unnecessary tests. Use these adjunctive measures.
Precisely. And only after you're reasonably confident it really is an exudate do you start thinking about more specific targeted tests.
Like adenosine deaminase, ADA, for TB.
Right? Or specific immunologic markers.
Yeah.
But these are ordered based purely on the clinical context. You don't just reflexively order ADA on everyone. You order it if the suspicion is high, fevers, night sweats, the right patient background, exposure risks. It's about being selective to avoid waste and get to the answer faster.
Okay, great. Now that we've sorted out the diagnosis, let's shift to management. Starting with the transudative effusions. The principle here seems simple. Treat the underlying disease.
Deceptively simple, yeah. The effusion itself is just a symptom of that pressure imbalance, either hydrostatic or oncotic. So for heart failure effusions, it's all about maximizing guideline-directed medical therapy, GDMT. That means the whole package for HFrEF or HFMR-AEFA patients. Diuretics, yes, but also pushing the ARNI like sacubitril/valsartan, beta blockers, MRAs, and now the SGLT2 inhibitors.
And for us as hospitalists, it's not just about prescribing them, it's about optimizing them, right? If someone comes back in with a persistent effusion, we have to ask, are they actually taking their meds? Is the dose maximized? Or is this signaling that their underlying heart function is worsening?
Just tapping the fluid without addressing the GDMT is really just inadequate. It's like bailing water without fixing the leak.
Good analogy. What about cirrhosis with hepatic hydrothorax?
Similar principle, different details. First line is sodium restriction and diuretics, typically spironolactone, often with furosemide added.
Now here's a really important point, a critical warning almost, that's different from other fluid overload states. What about non-selective beta blockers in these patients?
Yes, huge caveat. Non-selective beta blockers like propranolol or nadolol, which we often use for visual bleeding prophylaxis and cirrhosis, you have to be extremely cautious with them, sometimes even stop them if the patient has refractory ascites or hepatic hydrothorax.
Why is that?
Because while they do lower portal pressure, which is good for varices, they can worsen systemic hemodynamics. They can drop the blood pressure too much, increase the risk of precipitating AKI, or even worsen hepatic encephalopathy because you're reducing overall systemic perfusion. So often in the hospital, when someone's overloaded like this, we have to dial back or hold those beta blockers until they're dry.
Okay, crucial distinction. Now, what if the hydrothorax just doesn't respond? They're on max diuretics, salt-restricted, but still symptomatic, still accumulating fluid.
Then you move towards procedures. Usually you start with repeated therapeutic thoracentesis, just draining off fluid for symptom relief.
But that gets burdensome.
Very. For the patient, for the healthcare system, lots of visits, procedures. And that's where indwelling pleural catheters, IPCs, have started to gain traction, even for these non-malignant refractory Transudates.
I know the data's evolving, and meta-analyses support their use now. But what's the key trade-off you need to discuss with patients when considering an IPC versus just keep doing serial taps?
The main trade-off is the risk of complications, especially infection. IPCs definitely offer better quality of life for many fewer trips to the hospital, more consistent symptom control at home. But the data shows a higher rate of pleural space infection, potentially emphysema, compared to just doing serial taps.
And in a cirrhotic patient who might already be somewhat immunocompromised, an emphysema could be catastrophic.
Exactly. So it requires really careful patient selection, meticulous teaching about catheter care, and good home support systems. You're trading convenience and potentially better symptom control for that slightly higher infection risk.
Okay, let's switch gears completely now to the exudative effusions. Here the stakes feel higher, especially with peritoneumonic effusions and emphysema. Things need to happen fast.
Absolutely. You need rapid risk stratification. We kind of think about it on a spectrum, right? Simple peritoneumonic effusion, basically just inflammation next to pneumonia, likely sterile, should resolve with antibiotics alone. Then you have the complicated peritoneumonic effusion. That's where infection is likely present in the pleural space, signaled by those biochemical red flags. Low pH, usually under 7.2, low glucose, high LDH. Management definitely changes here. And then there's frank emphysema. You pull out gross pus. That's an automatic indication for drainage.
So the core management has two arms running in parallel from the start.
Right. First, get appropriate antibiotics on board early, often broad spectrum initially, then tailored once you have culture results. That's non-negotiable. Second, for any complicated effusion or frank emphysema, you need prompt drainage. Usually that means placing a chest tube, and critically, it must be guided by ultrasound for safety and to make sure it's positioned effectively.
Now, what about those really tricky ones, the loculated effusions, the ones where a single chest tube just doesn't drain well because the fluid is walled off into pockets?
Yeah, those are frustrating. Simple drainage often fails. This is where the MIST-T2 trial really changed practice years ago.
Right. That trial showed the benefit of putting enzymes or fibrinolytics directly into the pleural space.
Exactly. The evidence now strongly backs using intrapleural therapy, typically a combination of tissue plasminogen activator, TPA, and DNase. These drugs help break down the fibrin septations and the thick, purulent material, essentially liquefying it so it can drain out the chest tube. It often helps avoid surgery.
Can we get specific on the regimen? For the hospitalists listening, how is this typically done?
Sure. A common approach is sequential instillation. You might give, say, 10 milligrams of TPA through the chest tube, clamp it for an hour or two to let it work, then unclamp it. Then maybe on the next cycle, or sometimes combined, you'd give 5 milligrams of DNase, clamp for a dwell time, then unclamp. This cycle is often repeated, maybe every 12 hours, usually for a total of about 3 days or 6 doses.
Okay, that dwell time is key. And what's the trigger point for saying, okay, this medical approach isn't working, we need surgery?
Generally, if you've had the patient on appropriate antibiotics, they have a well-placed chest tube, you've given them the full course of TPA, say over 72 hours, and they're still not improving clinically, still febrile, septic, or the imaging shows persistent undrained collections, that's the time to escalate.
And escalation usually means surgery.
Yes. Typically, it involves video-assisted thoracic surgery, or VATS, where the surgeons go in, clean out the pus and debris, and perform a decortication, basically peeling off the thick inflammatory rind that forms on the lung surface, allowing it to re-expand. And timing matters here. Getting surgery done earlier, often within the first week or so, generally leads to better outcomes than waiting until things become chronic and that peel gets really thick and organized.
Let's touch briefly on tuberculous effusions. Still a challenge in certain areas and populations.
Definitely a challenge, mostly because the fluid itself is often pus bacillary. That means there are very few TB bacteria actually in the pleural fluid. So your standard tests, the AFB smear, and even the fluid culture for TB are frequently negative, maybe only positive in 20–30% of cases.
So you can't rely on the usual microbiology workup to rule it out quickly.
Not really. This means you often have to rely more heavily on tests like nucleic acid amplification tests, or NALATs, on the pleural fluid, which can detect bacterial DNA even if the bugs aren't growing. Or sometimes you need a pleural biopsy to get tissue for histology and culture. ADA levels can also be very helpful in the right context.
And treatment, once confirmed.
It follows the standard multi-drug anti-tuberculosis regimens, usually for about 6 months. The key thing clinically is to be really aware of drug interactions, especially with rifampin, which messes with the metabolism of many other drugs. This is particularly important if the patient also has HIV and is on antiretrovirals. You often need careful dose adjustments and monitoring.
Okay, shifting again. Let's talk about malignant pleural effusions, MPE. Here, the whole goal changes, right? It's not about cure, it's about palliation.
Entirely. The focus shifts completely to relieving symptoms, mainly shortness of breath, improving the patient's quality of life, and trying to minimize the need for repeated, often uncomfortable procedures, especially towards the end of life.
So what's the very first step when you diagnose an MPE?
The first step is almost always a therapeutic thoracentesis. Drain off a good amount of fluid. This does two crucial things. One, it provides immediate symptom relief, which is paramount. But two, and maybe even more critically for long-term planning, it's a diagnostic test in itself. You need to assess, does the lung fully re-expand after you take the fluid off? And does the patient actually feel better? Do their symptoms improve?
And the answer to those questions, especially about lung re-expansion, dictates the next step.
Absolutely. It determines the long-term strategy. Basically, you're choosing between two main options: talc pleurodesis or placing an indwelling pleural catheter, an IPC. Talc pleurodesis is usually done in the hospital. You instill sterile talc into the pleural space, which causes inflammation and essentially scars the two pleural layers together, obliterating the space so fluid can't reaccumulate. The goal is a one-time definitive procedure.
Versus the IPC?
Right. The IPC is a small catheter left in place that tunnels under the skin. It allows the patient or a family member or home nurse to drain the fluid regularly at home, maybe a few times a week. It offers continuous management, usually a quicker discharge from hospital, and often faster symptom relief compared to waiting for pleurodesis to work.
So how do you choose between them? You mentioned lung expandability is key.
It's the single most important factor in that decision matrix. If the lung does not fully re-expand after that initial therapeutic tap, what we call non-expandable lung or trapped lung, then pleurodesis is absolutely contraindicated.
Why contraindicated?
Because for pleurodesis to work, the two pleural surfaces, the visceral pleura on the lung and the parietal pleura on the chest wall, have to come into contact so they can fuse together. If the lung is trapped down by a thick fibrous peel on its surface, or maybe a tumor blocking a major airway, it simply cannot expand to touch the chest wall. If you put talc in that situation, it won't work. The space won't obliterate, and you'll just cause the patient pain and inflammation without any benefit.
So if you see trapped lung on that post-thoracentesis assessment,
the decision is made for you. An IPC is the preferred, really the only appropriate option for symptom control in that scenario. The goal becomes simply managing the fluid volume at home to keep the patient comfortable.
That makes sense. The IPC basically manages the space as a chronic fluid-producing cavity that just needs periodic draining.
Exactly. It dramatically improves quality of life in that palliative setting when pleurodesis isn't an option.
Okay, let's tackle some complex scenarios. How about managing effusions in critically ill patients, particularly those on mechanical ventilation? Sometimes there's hesitation to drain them.
Yeah, there's always concern about complications in the ICU setting. But there are actually conditional recommendations for drainage, specifically linked to how hypoxic the patient is. If their oxygenation is significantly impaired, typically defined by a PO2 to FiO2 ratio less than 200, and the effusion is estimated to be fairly large, say over 500 millibel, then drainage is generally recommended.
And the rationale is?
The thinking is that a large effusion in that setting is likely contributing significantly to compressing the lung, causing atelectasis and worsening ventilation-perfusion mismatch, or shunt. Draining the fluid has been shown to improve oxygenation parameters in these specific patients. It might allow you to reduce ventilator support, lower the FiO2.
But the risk of pneumothorax is still there, maybe even higher in ventilated patients.
The risk is definitely present, yes, which again underscores why ultrasound guidance is absolutely mandatory for any pleural procedure in the ICU. You need to know precisely where the fluid is, where the diaphragm is, where the lung is. But the potential benefit of improved oxygenation often outweighs the risk in that select group with severe hypoxia and a large effusion.
And procedural technique matters everywhere, but especially here. We've hit on ultrasound guidance. What about the volume limit? The standard advice is usually limit removal to 1,500 millilel per session.
Right. The 1,500 millilol limit is primarily to minimize the risk of re-expansion pulmonary edema, or REPE.
Is that number absolute, though? Is 1,500 millilel some magic threshold?
Not exactly magic, no. It's more of the consensus guideline based on observation. The risk of REPE seems to be more related to how long the lung has been collapsed and how much negative pressure is generated during the drainage rather than just the absolute volume removed. But sticking to around 1,500 milliliter, especially if you're draining quickly, is generally considered the safest approach in routine practice. If you need to remove more, doing it slowly, maybe even using pleural manometry to monitor the pressure changes, if you have that available, is probably wise.
Okay. And just to reiterate, if you encounter that non-expandable or trapped lung after draining,
IPCs remain the mainstay for symptom management, if palliation is the goal. Pleurodesis is out. Surgical decortication, actually peeling that rind off the lung, might be an option in very highly selected cases. Perhaps a younger patient with a non-malignant trapped lung or someone with a very good cancer prognosis and performance status, but it's a major operation.
definitely a big undertaking requiring careful multidisciplinary discussion about risks versus benefits for that individual patient.
Absolutely. Now, about monitoring after the procedure. Vigilance for complications like pneumothorax, bleeding, REPE is key. But one thing that's changing is the idea of routine post-procedure chest x-rays.
Ah, yes, I was going to ask about that. Many places still get a CXR on almost everyone after a thoracentesis. Why are guidelines moving away from that?
Basically, because the yield is very low in asymptomatic patients when the procedure was uncomplicated and ultrasound-guided, you end up doing a lot of x-rays, exposing patients to radiation, incurring costs for very little benefit. The recommendation now is generally not to do routine post-procedure imaging unless you suspect a complication. The patient develops new shortness of breath, chest pain, hypotension, or if you know you aspirated air during the procedure. Otherwise, trust your clinical assessment, maybe a follow-up POCUS if needed.
That's a practice changer for many of us. One last point on complications, IPC infections. What's the approach if an indwelling catheter gets infected? Do you automatically pull it?
Generally, no. The approach for most IPC-associated infections is to treat with systemic antibiotics without routinely removing the catheter. You'd only consider removing it if the infection isn't responding to antibiotics, if the patient is severely septic, or maybe if the skin site looks really bad. But remember, for many patients, that IPC is their lifeline for symptom control. Removing it means going back to repeated taps, which might be much worse for their quality of life. So try to treat through it first.
Okay, that framework is incredibly helpful. This all sets the stage for thinking about prognosis and really highlighting the hospitalist role in managing these patients.
And the prognosis, unfortunately, is often quite poor across the board. We tend to focus on malignancy, but as we said earlier, those non-malignant effusions tied to end-stage organ failure, heart, liver, kidney disease, they carry a very high burden. One-year mortality rates can easily be in the 25 to 50% range.
And it's almost counterintuitive, but sometimes those bilateral transudative effusions actually signal a worse long-term prognosis in the non-malignant setting, right? Because they reflect such advanced, maybe refractory systemic disease.
That's exactly right. They tell you the underlying organ failure is profound. Malignant effusions, of course, also signify advanced cancer, usually stage 5E, and survival is often measured in just months, which reinforces why our focus has to be on palliation and quality of life.
Which brings us to our role as hospitalists. We're really central to this whole pathway, aren't we? We're often the first diagnosticians, the ones doing the initial risk assessment, coordinating the care.
Absolutely. Our role starts right away with that rapid evaluation, leaning heavily on POCUS now for quick, safe assessment. We're the ones making that initial stratification. Is it bilateral and likely systemic, or unilateral, and needing an urgent tap? We initiate the GDMT for suspected Transudates. We order and interpret that crucial pleural fluid analysis. We coordinate the thoracentesis itself.
And maybe most importantly, we're the orchestrators of multidisciplinary care. For the complex or recurrent ones, we're the bridge to pulmonology, maybe for bronchoscopy or advanced procedures, to interventional radiology for drains or IPCs, to oncology for cancer-directed therapy or palliative care involvement.
That coordination, ensuring timely escalation, is vital. Pushing for those advanced options like IPCs or pleurodesis when medical management fails, or getting surgery involved early for emphysema. And perhaps the hardest part, but essential, is leading those difficult conversations with patients and families about prognosis and goals of care, facilitating shared decision-making around these often palliative interventions.
So, if we were to summarize the key takeaways for you listening today, the big picture is really about a systematic shift. We're moving towards ultrasound for diagnosis and procedural safety as the standard, and management has to be highly tailored based on the cause. Maximizing GDMT for Transudates, being aggressive with drainage and adding TPA-DNAs for complicated pneumonics, and recognizing IPCs as the go-to for symptom control in trapped lung with MPE.
Yeah, I think we have pretty clear guidance now for the complicated infections and for malignant diffusions. We have algorithms. But, the biggest remaining question, the area where we still need more research and maybe better long-term solutions, it's how to best manage those refractory benign effusions long-term, the ones from heart failure or cirrhosis that just keep coming back despite maximal medical therapy. IPCs are an option, serial taps are an option, TPS for some liver patients. But truly optimal, durable, non-surgical strategies, that's probably the biggest evidence gap we face right now. And it demands really careful, individualized care until we have better answers. That's where hospital medicine needs to keep pushing.